get through, so I'll try to get through in a reasonable time and hopefully a little early. But I was going to talk today about cost effectiveness in general with some hearing health research kind of examples to help you keep it grounded and somewhat otology related. But this is mostly kind of a methods talk about cost effectiveness and cost effectiveness analyses. And so I'll get started. Can't advance my slide here for reasons. Okay, there we go. Okay, so the central question that really outlines most health economic analysis is how can we maximize benefits in the setting of limited resources? And I know, especially in America here, it's tempting to think of healthcare as a resource that has no limits. But certainly the value of care and services has a voice, and it's a piece of the puzzle in coverage determinations, however transparent those might be. And in some jurisdictions around the world, the UK and the Australia and to some extent Canada are good examples. Cost effectiveness is actually a major driver of those sorts of decisions, and so ones that many manufacturers, pharmaceutical industry, and payers are interested in. So I think it's a valuable language for us all to be able to speak, for us to understand the methods of cost effectiveness analyses can provide some value. And so I'm going to try to give an outline of that for you all. So my goal today is to promote an understanding of cost effectiveness analyses and to try to give you guys enough knowledge to not only critically evaluate the evidence, but also to understand some of the existing evidence in hearing health. And I'm going to focus mainly around one paper, actually, in a model of hearing screening cost effectiveness to try to help illustrate all the points along the way. But we'll also talk a little bit about cost effectiveness of cochlear implantation. These are probably the topics that receive the most focus in cost effectiveness studies in hearing health. So another point here about what this talk is and what it is not. There's many different types of health economic evaluations. There's cost minimization studies where basically we're just trying to find the least expensive series of things that we could do to a patient to arrive at the same outcome. There are cost effectiveness analyses where the outcomes might vary some and the costs might also vary, and we're trying to decide if the incremental cost is justified. There are cost benefit analyses. Essentially, they're really similar to CEAs or cost effectiveness analysis, but what we're doing here is converting all of the benefit that we get into a monetary unit like money, which is an easier language for a lot of people who deal with money to explain, to understand. So, but frankly, they're not really often done in health economics for a variety of reasons that I won't get into right now, but mainly it's because it's sometimes difficult to translate benefits into cost. And then lastly, there's budget impact analyses, and this is really just trying to determine if we implement the strategy that we think is best and most effective, can we actually afford to do that? So just considering the population size and the disease prevalence and the budget available, is it like a feasible solution to implement in terms of coverage? And this talk is focused like pretty much exclusively on cost effectiveness analysis and not any of those other things. So I'll first start by giving you an outline about like how we think about the question and try to help decide, what exactly are we trying to answer and whose opinion are we talking about. I'll next talk about the different features of these models, the costs and the effectiveness, and then we'll talk about how to interpret the results. And then modeling gets like a little into the weeds, but I'll try to give you guys a broad overview of how things are generally modeled and what simplifications we make and which ones we think are important to not make. And then we'll talk about, I think this is like one of the most important parts about modeling in general, but certainly in cost effectiveness, which is how we deal with uncertainty. And then lastly, we'll talk a little bit about some controversies with some recent political action around cost effectiveness analyses, and also talk about how we measure effectiveness in different ways, especially around hearing. So first, this framing the question piece. So the very first question that is asked in a cost effectiveness study is, whose opinion are we talking about? Who cares? I don't mean to imply like no one cares, but we're talking about whose consequences are we considering, And most often, this is the healthcare sector or healthcare system. But sometimes we do take a broader perspective of like the entire society, and we consider things outside of healthcare, like the time and productivity and opportunity cost of time, and influence on caregivers and dependents as well. But I'll say most oftentimes it's the healthcare sector we're talking about. And then the second question, when we frame what we're talking about, is the time horizon. So how long are we considering the impact of the decisions that we're making? Again, oftentimes, especially in otology, we're focused on the lifetime of the patient. We're talking about decisions that are going to have an impact for the remaining time that that person's alive. But sometimes a shorter time horizon is more appropriate if you're thinking about something that might only affect an inpatient hospitalization, for example, or only affect perioperative outcomes. Then maybe a short-term outcome can be considered. But like again, more oftentimes it's a lifetime time horizon. So here's a quick introduction to the study that I'm going to use to try to help describe all of these things. And this is a hearing screening model that was published fairly recently. It basically is looking to determine whether or not different screening schedules for hearing in older adults have cost effectiveness. So that matters based on what age we start screening and how frequent we screen. The perspective that they took is from the healthcare system, and the time horizon is lifetime. Okay, so now going into the next part of it, which is also fairly straightforward, is this idea of costs and the different cost categories. So the different costs that we can consider can be categorized in a way that I think most of you are probably somewhat familiar with in terms of budgeting, and these are direct costs. So things that are like directly attributable to that episode of care, and you can think of them also as something that you might receive a bill for associated with that episode of care. There could be medical direct costs that have to do directly with the intervention itself. And there are non-medical direct costs as well, like getting transported to the care, or having to stay overnight, for example, or having to look at childcare while you're receiving care. And then there are also indirect costs. And most of the time, although it's not explicit in the definition, but most of the time in indirect costs, we're talking about the cost of time, like the opportunity cost. So that the patient is spending time in treatment or recovery, and maybe they're not spending time at work, or they're having to or someone else is having to look after them and also missing time at work, for example. And that can be considered during the treatment, but also in the outcomes for the treatment as well. And then lastly, there's this little piece called intangible costs. And sometimes this is grouped in with the cost categories, but more often we take these things and we lump them in with the effectiveness side of the equation as a sort of like negative effectiveness, because they're a little bit easier to measure with some of the different ways we measure effectiveness than they are with costs. But suffice it to say, they are technically considered a category of cost. Okay, so quickly back to that hearing screening study. So we looked at direct medical costs, and there's a small group of the costs that are considered there listed, but the model is much more complicated than that. So there are many other costs, but just to give you an example of what we're sort of focusing on, are really just direct medical costs in this study. So okay, here's where things I think start to get a little bit more interesting and more nuanced. But the next piece here is how we measure effectiveness in cost effectiveness studies. So occasionally there's an outcome that we're interested in that's really easy to count, that is just naturally countable. So we call these natural units. And they're really only useful when we're not interested in any other consequences of the strategies that we're considering. But practically, I would say that that's not a common scenario. And most interventions are going to have consequences beyond what you even might consider or plan, but certainly beyond one of the natural units. So cost effectiveness analysis using natural units of effectiveness are out there, but more often than not, we use a more comprehensive measure like quality of life. And so this is just an outcome that's looking at, all the different ways that an individual can be impacted, and it's used in part as a way to calculate the most common outcome and cost effectiveness studies, which I'll get to in a sec here. And then when we're talking about healthcare, we're not really talking about all of quality of life. Typically, we tend to exclude, for example, people's political or economic circumstances. So we're talking about health-related quality of life as a subset of quality of life. And also, we also know that people's quality of life can vary over time, right? And so if we're modeling people's quality of life and how it might change with different interventions and different disease progressions or different incidents of new disease, then we have to somehow calculate the cumulative quality of life over time. And the way that we tend to do that is just by multiplying some measure of quality of life by some measure of time. Okay. And so using a measure that we can justifiably multiply by time is ideal. And so that measure should have something called interval properties. And the outcome that we usually use is called quality adjusted life years. Okay, so the next question here is, how do we measure quality of life in an instrument and an output measure that satisfies all those criteria for us to be able to multiply by time, and for one that has interval properties. And the most common measure that's used is something called health utility. So health utility is on a scale. You can see here it's anchored typically at 0 and 1, and being 0 being dead and 1 being in perfect health. And then there's states in between. And in fact, you can have states that are worse than dead as well, that have negative health utility. If you consider a state that might be less preferable than being dead, and being in severe pain and bedbound. But for the most part, they're from between 0 and 1. And this is an interval scale. So, the difference between 0 and 0.1 is equivalent in terms of people's preference to the difference between 0.9 and 0.1. And that lets us multiply it by time. And as I mentioned, it represents individuals' preference. And this is all well and good, but until you consider how do we actually estimate somebody's preference and put them on this scale between 0 and 1. And I'll try to use an example of moderate hearing loss to try to help illustrate how we do that. But one way to do it is by using thought exercises. Okay, so the most common example of this thought exercise is one where you provide the individual or respondent, and you say, okay, well, you've got moderate hearing loss. You might describe what it's like, or they might have that condition, and you offer them a choice. Okay, and the choice is they can stay in that current health state for the rest of their life, or they could try, this magical treatment that has no side effects and has immediate results, and that gives them the opportunity to restore themselves back to perfect health. And it has a certain probability of doing that, but it also carries a risk of killing them instantly. Okay, a painless death, but an instant painless death right away. And so we then start to vary those probabilities until that individual reaches decisional equipoise, right? Or at least on a population level, we reach the average decisional equipoise. And that gives us an impression of how valuable that health state is relative to being dead or perfect health. And you could imagine doing this scenario if you were looking specifically at hearing loss. You could do it for hearing utility relative to, let's say, no hearing or perfect hearing, to try to help quantify that health state. And this exercise is called the standard gamble. But there's many different exercises that you could use, and collectively those are called direct elicitation exercises. But as you know, as you can imagine, those are time consuming, right? They involve all these exercises. There's a lot of back and forth. And so more commonly we use this indirect approach, where we basically take the individual and we categorize their quality of life or their current health state really into a state that we already have defined utilities for. So we take somebody, we ask them a series of questions that tries to help, pigeonhole them into a health state that we've already quantified. And then we say, okay, well, your utility is approximately this, because we know other people who have answered those questions in that way have given us direct elicitation to show their utilities is this. And this is called indirect elicitation. And there are two parts of utility instruments. The first part is asking the patient, well, how well can you hear, for example, or how much pain do you have, or how good is your memory, and quantifying their health state. And then the second part is just translating that health state into utility. Okay. And there's a number of different utility instruments, and many of you probably have seen these utility instruments around. You may or may not have recognized them as being utility instruments, but they're a specific and special kind of health-related quality of life measure that outputs this special score called health utility. And this is just sort of like a subtle side point, which is that when we have cost effectiveness analysis and the outcome is QALYs, or quality adjusted life years, is the most common outcome, we call them cost utility analysis. So you kind of you'll see those terms used interchangeably when we're talking about a quality outcome. Okay, so back to our hearing screening study. This was, in fact, a health utility study. So they did use utility and quality adjusted life years as the outcome measures. And you can see that they kind of scoured the literature to try to find different utility values that were associated with different hearing states that the individuals might be in their model. And the different utility benefits for the interventions they might receive, which in this case was really either a cochlear implant or a hearing aid. And if we look next at the kind of main result table from this paper, you can see that there's the different screening strategies that are outlined here on the left side, starting at an older age and then getting progressively younger, and also starting at an interval of 5 years, and then also testing an interval of annuals screens. And you can see that over time, with each successive kind of more intensive screening regimen, you can see that the effectiveness does improve. The number of QALYs over the remaining lifespan of these people, who, by the way, all started at sort of age 40 and then were followed for their lifetime. And then that's compared to, you see that the costs are also kind of incrementally increasing over time. Okay, so we have ourselves a question here of whether or not this incremental benefit is worth that incremental cost. Okay, so how do we now interpret these results? So this is kind of the meat of cost effectiveness studies. And this is just sort of a grid that shows you the different quadrants that you might be in when you're considering the relative costs and effectiveness. So if you're in this quadrant here, where the intervention that you're considering compared to some baseline intervention within this, which in this study is no screening, the intervention we're considering is now more effective and it's less expensive. Well, I mean, like we're done, right? Like this is it's overall better, it's cheaper, so we don't have to do anything else. We've decided that this is better. And similarly, like if it's worse and more expensive, well, like we trash it, right? We don't have to go any further. But the interesting stuff happens in this in between, where either the strategy is more effective but also more expensive, or it's less effective but also less expensive. And the question becomes like, what's the difference in effectiveness and what's the difference in cost, and can we justify it? And that's where we get this incremental cost effectiveness ratio. I think someone out there has got some mic action. The change in cost divided by the change in effectiveness gives us this ICER, or incremental cost effectiveness ratio. And there's one other point that I have to make, and it's like there's like never a really good time to make it, so I'll try to make it here. But that is that the timing of these benefits matters, right? So if you consider a scenario where an intervention costs something now, but the benefit isn't received for several years down the road, well, that's probably less desirable than receiving all the benefit up front and getting to pay later, right? Because there's the time value of money in terms of the cost of capital, but also there's a preference for benefits to happen up front. And the way that we model that or account for that time value of money is that we actually use something called discounting, where we take the future value of any costs or benefits, and we decrease it by a certain amount depending on how far in the future that happens. And there's a formula for it, and we usually use a discount rate of about 3 to 5%. So that's why you'll see discounting in many of the studies as you read them. So, okay, going back to that study and now uncovering some of the more complexities of that table, you'll see that there is the undiscounted and discounted benefits, and then there's a column on incremental cost effectiveness. So let's look first at the first screening strategy, which should be, as far as we hypothesize, the least expensive and probably the least effective, which is that we start screening at age 75 and we do it once every 5 years. So we do get an incremental benefit, and it comes at an increased cost. And the ICER is just under 40 grand. Okay, and the question is that worth it? Well, and deciding if it's worth it is not a super straightforward question. But as I'll get to further down the road, we usually present some graphs that show you at different thresholds of quote unquote worth it. But the general idea being that we usually use a willingness to pay threshold of some number, meaning that there's a number where we say, okay, a year of perfect health, which is what a QALY is, a year of perfect health is probably worth it if the intervention costs less than X amount. And that amount, some time ago, like 20, 30 years ago, was probably about $50,000 per QALY. But more recently, the threshold is pretty consistently used of $100,000 per QALY. So if we go back to that, that number is generally considered worth it in most people's verbiage around here. So that first strategy is cost effective compared to doing nothing. And now we look at each successive strategy, and then some other interesting things can happen as we gain some benefit at the expense of increased cost. And we can see here through some of the increments of screening of frequency, or really of screening age, as we decrease the age through 65 and 55 and 45, we're getting increased cost with not much increase in benefit. And then all of a sudden in the next strategy, we see that as soon as we drop the screening frequency to once a year, well, yes, the cost goes up, but actually the incremental quality of life benefit goes up considerably more. And when you see that kind of inflection point in these graphs, we consider that something called a weak domination. So the incremental benefit is considerably better for the cost, and the ICER is still within the willingness to pay threshold. So the difference between the current strategy and that 75Q1 is still below $100,000 per QALY. So we can say that those strategies in the middle, like no one is going to consider those strategies to be a better idea from a cost effectiveness standpoint than the 75Q1. And so this is the final complete table, and you can see those 3 weakly dominated strategies. And then further over here on the left, you see those annual screening strategies. The ICER gets consistently more expensive, or more cost per QALY as we go up. And somewhere around that 55 age is when we hit the $100,000 per QALY limit, and that's where we start to say, well, maybe starting to get above that, these QALYs are starting to cost a little too much for my liking. And so the cost effectiveness threshold in this study, at least in terms of this base case, was around screening at age 55 annually. Okay, so maybe this feels like a little backwards, but this next part is for us to kind of understand how we got there. And this is sort of like looking, at the abstract and the results, and then going back and looking through the methods and making sure that what they did seemed legit. And the face validity of models in cost effectiveness is really important, especially for us clinicians who deal with these patients and see them see this happen on a daily basis, for you to understand and see okay, that seems to make sense, and you didn't really miss a big piece of the puzzle. That's like a critically important part of cost effectiveness studies. So I would really encourage you, if you're interpreting them, to go back and look at the models if you can. So the first and simplest kind of model, which is not the kind of model they used in this study, but this is just kind of a made up example, is called the decision tree. And these decision trees are fairly straightforward. Essentially, you have these strategies, those shown in those blue squares, that we could pick for the cohort that enters the model. And then there's various outcomes that could happen along the way. And you basically add up all of the costs and all of the effectiveness along each of these different pathways, and all the costs and effectiveness that are attributable to one screening strategy, are used to calculate the incremental cost effectiveness ratio. And this is pretty good for like simplicity, but like any model, I guess parsimony comes at a cost. And the important cost here is that everything happens instantaneously, right? Like you can't go backwards in the model. You can't if you had a hearing loss detected or undetected, then you can't now go back and have a screening. You can't decide to screen at some point in the future. And what happens to you earlier in the model doesn't affect the probability of what happens to you later in the model, without the model getting like insanely complex. And so to deal with this issue of time, the more common modeling strategy in cost effectiveness studies are something called state transition models, of which the most popular is called Markov models. And so in state transition models, it's a pretty straightforward concept. Essentially, you have a bunch of different states that any individual could be in, and each individual then has a probability at each interval of the model of moving to a different state or staying in the same state that they're in. And at the end of the day, after the whole, in this example, the lifespan of the patient has expired, then you add up all of the costs and effectiveness of each transition and of each state that they went through, and then that helps us decide what our incremental cost effectiveness ratio is. And this simulates changing health much better. It allows us to, for what happened in the past, to modify the probability of what happens in the future. And overall, this is just much more realistic. But this complexity, of course, also comes at a cost, and mostly that's around computational burden. So you'll see in this kind of study, and as soon as we start getting in the sensitivity analysis, the number of times that we have to run these studies, it can take a long time. Even in relatively simple models, we're talking about with like powerful like cloud-based computing still taking hours or days to run these models is not uncommon. And there's also like another subtype of models, and this is separate from that decision tree or Markov model, but more often we're talking about Markov models here. And that's whether we run an entire cohort through the model at the same time, that has, like, for example, a certain risk of hearing loss and a certain risk of transition to a mild hearing loss, certain, probability of using a hearing aid. Or if we take individual patients, right, and run them through the model, and each person has their own set of probabilities based on, like, let's say their age and sex and their comorbidities and so on. And that obviously this kind of micro simulation model where you run individuals through and then average all of the results gives us a little bit more realism and gives us a little bit more variability and control over the model. But again, comes at the cost of complexity, because now we have to run the model for each individual, and sometimes it's hundreds of thousands or even millions of times that we run the model. And then when we do sensitivity analysis, there's an exponential number of times that we run the model as well. And this study that we talked about, this screening study, was a Markov cohort microsimulation model, which is probably one of the better types of models and one of the more commonly used ones in this kind of scenario. Okay, so the next part here, and this is the last sort of part about understanding cost effectiveness analysis, is around modeling uncertainty. Okay, so we have a list of all the parameters, and it's not important if you can read them or not, but just know that there are a lot of parameters that go into the model, and this is even just a small selection. Like, there's hundreds of them that go into the model, and these are all the state transition probabilities and the utilities associated with each one and the costs associated with each one. And there's uncertainty around every estimate that goes into it. And usually that's represented as some sort of confidence interval, right, or some standard deviation or some other measure of uncertainty. But when we run the model at first, we just run what's called the base case, and the base case is just by taking the average and putting it through the model and ignoring all the uncertainty. And that's what we showed in that initial table that I showed you. Those ICERs we showed you before, those are the base case ICERs. But after we do that, we need to figure out how sensitive the model is to the conclusions that we drew. In other words, if we vary some of these things, are we going to drastically change how we conclude, what we decide is the best strategy? And if so, then, maybe the conclusions are not super robust. And the first and the easiest and most basic and simple way to do this is just to vary one parameter at a time. So for example, like here, you vary the cost of an audiogram along its possible range from about 150 bucks to 600 bucks. And we see how much does that affect the incremental cost effectiveness ratio for that 55, Q1 screening strategy compared to no screening. So for each pair of ICERs, you need to do each individual parameter, and you vary it along the range of its plausible things, and we see how much it affects the ICER. And in this case, it looks like the cost of a diagnostic audiogram actually changed the ICER by quite a bit, like up to almost $200,000 per quality to well below the willingness to pay threshold of 100,000. So that was an influential parameter, and same with the screening effectiveness. And then, this is just a select few, and you usually present them in this kind of plot, which is called a tornado diagram. But this basically just shows you the most influential parameters in the model. And then the next part is that we vary more than one parameter at a time. And this just allows us to understand the interactions between parameters. So in this case, we're varying the hearing aid device cost, and we're also varying the screening effectiveness. And you can see based on this, which is just showing us, which of these strategies met the cost effectiveness willingness to pay threshold. And you can see that the screening effectiveness, as we vary the screening effectiveness, well, it did change, at what threshold of screening frequency we consider cost effective, whereas the hearing aid device costs, it didn't seem to make too much of a difference with a few small examples. Okay. And then this is the interaction between those two things. And so you do this for like a lot of different pairs of parameters as well. And then the last type of sensitivity analysis, and the one that in my opinion, most important, is something called a probabilistic sensitivity analysis. And the way that this works is basically that rather than varying things along the maximum and minimum range, we instead vary the parameters based on their distributions, okay, based on their likelihood. So most of these are sort of normally distributed, but there are some other distributions we use to model these parameters. And for example, the risk of hearing loss, well, let's say if the risk of hearing loss was, 50% in this cohort over the course of their life, well, it's likely that value is closer to 50% than it is to the extremes, like, 10% or 90%. And so using a normal distribution to model that is probably a little bit more effective. So the way that we do that is we randomly select from the distributions what the parameter is going to be, and then we run the model. And then we do that again. We randomly select all of the parameters, and then we run the model again, and again, and again, and again, and again. And then we do that for each individual in the micro simulation, right? For maybe 100,000 or 1 million individuals, and you might be varying the probabilities or the different all the different parameters 100,000 or 10,000 times. And so you can see how like an exponential number of models need to be run in order for us to get some output here. And then the output diagram is this one that you get from the probabilistic sensitivity analysis. And this is called the cost effectiveness acceptability curve. And it's a really useful diagram for you to see like a quick glimpse snapshot of the entire study. Okay, so at the bottom here, we're seeing the different willingness to pay thresholds. And on the right here, we're seeing the probability that the strategy we're looking at was the best one. Okay, and the best one is defined by being below the willingness to pay threshold and not being dominated by anything else. And so if you consider that $100,000 willingness to pay threshold, you can see that 55 Q1 in about 40% of the iterations was the best strategy. But that means that like in 60% of the strategies, something else was better. And so you can look at this one here, this current detection rate with the willingness to pay threshold. Of course, if we're not willing to pay anything for screening, well, then that's the only one that's acceptable. Okay, but as soon as we're willing to pay a little bit, and as soon as we're willing to pay about 50 or 60,000, then a different strategy becomes more effective. And so this is the way that you get over that issue of having a difficulty assigning what an annual quality of life, so a 1 year of perfect health is worth to you. You can see along the range about where the lines cross over and decide if that's an acceptable solution. Okay, the last part of my talk here is just a little bit about some controversies and new things in cost effectiveness studies. And the first is this bill that is currently under review called the Protecting Healthcare for All Patients Act. And the idea here, when it was introduced, is that there's a potential that QALYs can discriminate against people who have a shorter lifespan. Okay, so people who are either elderly and so they're lived part of their life. If we're comparing QALYs that are potentially gained by elderly people receiving an intervention, well, they're sort of disadvantaged that if we compare to like children who get some different intervention because they have their entire lives to be able to benefit QALYs. Okay. And similarly, people who have some disability, who have maybe a shorter lifespan and lower QALYs, well, they have a lower opportunity to receive benefit. And so if we're using these to make coverage determinations, there's a risk that we're discriminating against people who are either elderly or have a shorter lifespan or who have a disability. At least that's what people who support this bill are saying. And yeah, it went through the House and it's currently with one of the Senate committees. So they're going to make some adjustments likely and recommendations to it and then pass it to a Senate for the vote. But it's caused a little bit of controversy in the academic world, especially among people who who use cost effectiveness analysis and those who generate these models, with the main counterpoints being that that's not really how we use QALYs. Okay, so we don't really use them to determine treatment for a specific patient. Like physicians or other providers and even regulators, we're not considering like any individual patient's potential QALYs gained and using that to decide if they get an intervention. But instead, we're like considering a population who has a specific problem, and we're trying to quantify how cost effective those strategies might be. And another point made in this recent viewpoint was just that individuals who have some disability and who have lower health-related quality of life actually have more to gain. Right? There's a ceiling effect with QALYs. If we're relatively healthy, let's say our health utility is around 0.8 or 0.9, well, we can only get to perfect health. And so there are lots of scenarios where people who have disabilities, if they are exposed to an effective treatment, actually might be preferentially, those treatments might be preferentially funded if we use QALYs. And there's a bunch of other points that are made, and I encourage you to read that viewpoint if you're interested in looking at it. But that's one kind of controversial topic. And then the second piece here is around condition-specific health utility, which has been a research interest of mine for the last few years. And I'll remind you about indirect utility measurements. So you take an individual, you try to classify their health status, and then you assign a utility based on that classification. But the issue becomes like, what if we have a bunch of different people who we know have some different health-related quality of life or hearing-related quality of life, and the instrument doesn't ask the right questions of them and ends up categorizing them the same way? Well, then of course we're not going to see a health utility benefit for different interventions that bring people between those two health states because they're all classified as having the same utility. And this is a problem that we see in cochlear implantation, and specifically around bilateral cochlear implantation and in cochlear implantation for single-sided deafness and potentially some other treatment paradigms, where we can't measure a utility benefit for them. But even though we know that they're performing better, we can't measure a utility benefit because the instruments are not asking them the right questions. And so this is really important also because remember we talked about the sensitivity of these models and what parameters are important. Well, it turns out that basically every cost effectiveness analysis of cochlear implants that's ever been published shows that utility values for cochlear implantation are among the most important and most influential parameters in the model. So if we make just little changes in health utility, we have pretty dramatic changes in the conclusions of cost effectiveness studies. So to address that problem, we designed a new health utility instrument that tries to capture things that are not measured by existing measures. Okay, things like sound localization and tinnitus and effort and so on. And I won't go through how exactly we did it, but this new instrument is called the Hearing Utility Measure, or HUM. It's used in combination or in concert with the Health Utilities Index Mark III, which is one of the most common instruments. And it generates, it can classify almost like 26,000 different states of hearing, which should capture most of the different variabilities in hearing. And that's compared to just one of 6 different states that you'd be classified according to with the HUE 3. And we've shown through various studies that it correlates a little better with other measures of hearing-related quality of life and other audiometric measures. And this is just one example, the CIQOL, and we showed that some of the subdomains have much stronger correlations with our measure than they do with the legacy HUE 3. And importantly, in just kind of one proof of concept here, we do show that we're able to detect a significant improvement in hearing-related utility for single-sided deafness patients receiving a cochlear implant, whereas the HUE 3 could not. So I think that that's a valuable piece of information that's going to be used very shortly in some cost-effectiveness studies as well. Okay, so that's all I have. Kind of went through the different ways of designing and modeling cost effectiveness and how we interpret the results. And I hope given you guys enough of a fundamental understanding to be able to interpret some of those studies and at least now understand a little bit about the cost effectiveness of hearing screening and cochlear implantation. So I'm happy to answer questions if there are any. And if not, that's totally fine too. Cool. Well, my email is there. So if anything pops up and you would like to talk more about it, you're interested in it, or if you have any questions, anything was unclear, I'd be happy to correspond by email and chat, set a meeting, whatever you guys like. So thanks all for coming.
Thanks so much, Dr. Dixon. And this meeting will be recorded and placed on YouTube, so you can rewatch it and revisit it if you have any other questions or things you think of later.
Hi, Peter. Great talk. In your research or through all this cost effectiveness, is there any ties to also improving the global warming kind of position or decreasing the carbon footprint of what we do in healthcare? Is there anything that ties to that? I know this is kind of out of the scope of your current talk, but I was just curious if there are also research efforts in that same vein.
Yeah, that's a really great question. And that kind of goes back to one of the first points I made, which is about perspective. So most oftentimes in a lot of cost effectiveness analysis, just for sake of model simplicity, because things can get out of hand pretty quickly, people just focus on the healthcare system. But there are certainly societal costs of what we get up to. And those come both in monetary costs, but also in environmental costs and in other social consequences. So there are definitely studies out there that take a broader perspective. I reviewed one pretty recently, actually, about telemedicine in cochlear implant care, looking at the environmental impact of reduced travel and tried to quantify the not only the monetary cost, but also the environmental cost of that. So certainly these techniques could be used to answer those sorts of questions.
Dr. Dixon, could you just briefly touch on translating this information from the Canadian healthcare system, which you have experience with, to the US healthcare system?
Yeah, absolutely. So the way that the U.S. healthcare is different from everywhere else is that there, of course, is no like universal single payer, right? So in a lot of other health systems, there's at least a dominant payer. In Canada, it tends to be a single payer for each province. And in the UK, for example, there's a National Health Service. There is a private health system as well, but a lot of care is delivered through the National Health Service. And then similarly in the UK, in Australia, they have a similar model. And in those jurisdictions, and I can speak to this most from Ontario, where I'm from, but essentially there is like there's a regulatory kind of institution, which is the Ministry of Health that ultimately makes the funding decisions, but they kind of rubber stamp most things that are recommended to them. And then there are all of these sort of like committees or groups that review all the cost effectiveness and effectiveness evidence and then make recommendations. But the difference is, I will say, is that cost effectiveness is much more transparently a part of the process in those other jurisdictions than it is in the US. But I really am hesitant to make the assumption that cost effectiveness plays no part in these coverage determinations. One way you might see it make a difference is in sometimes when people when different insurers are making decisions about kind of low procedures or interventions that are given with inappropriately often, or ones that require pre-authorization, for example, those ones might be ones that they find are maybe not super cost effective, or maybe that the effectiveness is not justified for how much it costs the insurer directly, and so they're maybe making sure that things are applied in appropriate ways. But it's much less transparent. So we can only assume that these kind of things are going on in the background, but the reality is with a privatized system that they're not obligated to share that information, and so we just don't know.
Awesome, thank you. Well, if there are no other questions, I want to thank Dr. Dixon for his time today and for doing the first Nerve Series lecture of this year. Please look out for more emails from me regarding future lectures.
Thanks all for coming.
Thanks, Dr. Dixon.